When one compares surgery to radiation, there are some critical differences. For instance, the benefit of radiation is that there is no hospitalization. There are radiation therapies such as Cyberknife, which are heavily advertised now, that require only 5 treatments over 2 weeks rather than daily 5 days a week for 7 or 8 weeks as with traditional radiation therapy. However, I should point out that for men with Gleason 4 + 3 = 7 or higher grades, that is grade group 3 or higher unfavorable intermediate risk disease, these men, if they chose radiation therapy, should also have hormone therapy along with the radiation because the outcomes in terms of cancer control is better. However, for men with higher grade cancers, unfavorable intermediate risk or higher, hormone therapy adds no added benefit if one opts for surgery. Some men don't like the systemic side effects of hormone therapy, which may include hot flashes, weight gain, decreased memory, or increased dementia actually long term. And we have found that for some men who are on hormone therapy for a longer period of time, there is a greater risk of metabolic syndrome, diabetes, coronary artery disease, and other undesirable health effects. Some randomized trials actually suggest that with radiation therapy, the duration of hormones that makes the cure rate higher should be at least 24 months. Therefore, use of surgery may help a man avoid those systemic side effects of hormone therapy. Finally, the definition of biochemical recurrence, or PSA recurrence, differs from surgery versus radiation. With removal of the prostate, the PSA should go to 0 or an undetectable level within 8 weeks. With radiation therapy, the nadir PSA may take anywhere from 2 to 5 years to occur, and treatment failure is defined as nadir plus 2. So if we use the example that a man's nadir PSA occurs 5 years after radiation therapy at 0.3, that man is not considered to have failed radiation until his PSA reaches nadir plus 2, or 0.3 plus 2, that is 2.3. That leads to a big gray area to define treatment recurrence, and that man has less options after recurrence is defined because of the lag in detecting a treatment recurrence. And so there are some nuances in terms of how treatment recurrence is defined, and that has implications for the timing of salvage therapies to try to get a cure. For instance, there's high-level evidence after surgery that if the PSA is rising, or the advantage of surgical staging demonstrating that cancer has invaded into the seminal vesicle, into the lymph node, that man may receive additional radiation therapy with curative benefit. With the shoe on the other foot, that is, if someone chose radiation therapy initially, the likelihood of getting a cure with salvage radical prostatectomy is very poor, or other salvage therapies after failed radiation.